Hi, welcome to Straight Talk with Tracey. Today I'm joined by Dr. Christopher Cutter, the Program Director for the Chronic Pain Recovery Center at Silver Hill Hospital. Dr. Cutter, thank you for joining us today.
Thanks for having me.
We have a lot to talk about,
We do.
I wanted to start with a definition of what is chronic pain.
Certainly. I usually like starting that off with what's the definition of pain. So pain is a sensory and an emotional experience for a perceived or real threat to the body. So if we just kind of dissect that for a second before we go into the definition of chronic pain is, besides the sensation of the pain sensation, wherever it's located in the body, the emotion engages as well to be able to tell the brain, hey, this is actually quite harmful. Please react in more of an intense way for survival or so we don't incur further damage. So the emotion kicks in rather quickly and abruptly when there is pain or a threat to the body. The definition of the chronic pain is that type of pain lasting 12 weeks or longer. So it can be either through true injury or all the healing has occurred and there's still the pain signal fired. So the way I take a look at it is a fire alarm. Say a fire alarm is going off in this building or in our homes, but there's no smoke. And it just keeps firing off. Or if there was, at one point, there was a fire alarm goes off like it should, fire's out, house is safe, but the signal keeps going and going and going, even though there is no more threat to the building. And that's got to be quite frustrating for somebody who's dealing with an injury that has completely healed, and the pain is still quite real, and the perception and the emotional reaction to the pain is still rather intense.
Interesting. So why is it that the brain keeps sending that threat signal?
So a great and an important question. We don't know, so it's just really hard to locate it because sometimes there are some ways we can catch it. Whereas, oh hey, well, we take a look at there's a split in your disc, and we can actually take a look at that, and that's where it's coming from. Or there might be a bone fracture that wasn't caught, or like basically a misdiagnosis. But sometimes there's not.
Right.
Or that we don't have the technology to really find and locate where it actually is. And that's a very frustrating piece for a person that lives with chronic pain, since the technology really isn't advanced enough to actually take a look at individual nerve fibers to see which one's misfiring. You can kind of take an approximation, but ultimately it comes down to we don't know, and we have to learn how to manage that pain because we don't know exactly how to turn it off.
So if the diagnosed medical reason for the pain has healed and there is no known source for the pain, do you still treat the pain medically?
Welcome to my world.
Yes.
Yeah. Okay, so we don't. We should stop eventually.
Okay.
So what you want to do is, obviously by the time a patient would get to me, they have exhausted all possibilities and went to so many different specialists to find, can you please just find out where the pain is and make it stop? And every expert has come back and said there is just no reason why you still have continued pain. And some people stop believing the patient. And family members stop believing the patient. And we eventually get to the understanding of, well, there's still this chronic pain going on. I'm going to have to learn to live with it, but not let it take my life over. So I have to learn ways to learn how to manage the pain, to turn the volume down, turn the pain signal down. So rather than it being at 8 or 9 all the time, can we get it to a 4? So the life interference factor is just not so dominant in these people's lives, which it usually turns out to be.
Right. So what kind of patients are coming into the Chronic Pain Recovery Center? What are you seeing as your what are the types of pain that people are suffering with?
So initially when I started off my training, I would take a look at non-specific lower back pain and not take a look at any others. But whenever I opened the door to helping people out with a bunch of different protocols and different techniques of learning how to manage the pain, everybody just started coming in. And this is a lab I had in a different setting. So just folks wanted to help with pain regardless of how I could be helpful, because usually folks are quite desperate by the time they reach me. So chronic headache pain, pelvic floor pain, musculoskeletal pain, nerve pain, some types often some types of cancer pain as well that we can be very helpful with. But I'd say cancer pain, there is definitely medical intervention combined with the techniques that we share. But say other folks that are not terminally ill, I can just say we have really run the course of all different types of chronic pain, and it's at this point dozens and dozens of types of pain. It really boils down to the multidisciplinary and interdisciplinary team that you approach how to treat sorry, let me backtrack that. Not treat, manage the pain.
So, Dr. Cutter, is the goal of the program to get rid of someone's pain? Is that a reasonable expectation, or is it individualized, dependent on the patient and their condition?
All right, so the typical doctor answer is, oh, it's so individualized, it's so different. I'd like to actually set up for success and say the goal will be realistically to learn to manage the pain and reduce the pain number. And that's actually quite realistic for most pain patients, to actually reduce the number to a manageable level so their quality of life is drastically improved, that their mental health is drastically improved, their physical health is drastically improved. But the pain number, we actually have to play around with what's realistic. Some folks, though, that do come through the door, and it's a small amount of the population, we might not be able to make an incredibly significant large dent. However, and again, that's a small number of the population that come through. However, we increase their quality of life. We have them help to learn how to manage the pain, even if it's pretty intense. But to not let it interfere with their life in such an incredibly intense way. It doesn't interfere with their families' lives. It doesn't interfere with their children's lives. In their lives, they can get back to work, but learning how to manage the pain in a way that's not so interfering.
Right. You mentioned emotional health or mental health, right?
Yeah.
I would imagine some folks that have been dealing with this and get to you are quite desperate.
Yeah, so it's a really sad part about living with chronic pain. It's one of the reasons why I really got attracted to the field in the first place. Prior to getting interested in chronic pain, I was very interested in depression, anxiety, mood disorders, and just personality disorders as well. It's just that emotional turmoil that someone struggles with, and how to create a really effective treatment to do that. And I just was so lucky to get linked in with the people and mentors that with my postdoc specialty to work with chronic pain, and how we work with opioid dependence and chronic pain at the same time. And the emotional component, it just overlaps so well that it was seamless to go into the field. That when I was working with chronic pain patients, I was truly working with somebody who has very intense major depression to the point where it's suicidal. Somebody with intense anxiety, and also a lot of PTSD comes in through a lot of chronic pain patients. So
from the pain experience.
Well, from the pain experience, also from the damage that has occurred maybe at the moment of time. With the injury that happened,
right.
Or just living with it day in and day out, and how intense it was, that we start seeing post-traumatic symptoms, maybe not true PTSD as a diagnosis, but certainly the symptoms. But a lot of other folks have come in through it, and their PTSD has, from prior to the injury, has exacerbated their pain levels. Right. And we do see that when people have increased stress and cortisol levels, that it just runs rampant and makes the pain flare up so much worse. And that is, again, one of the things that we do need to focus on is a pretty helpful mental health components. If I might add on, when we talked about earlier about the definition of pain, it is sensory and emotional experience. And so the emotional experience amplified with pain and amplified with anxiety just can make that pain signal really flare up, like adding gasoline to a fire.
Right. So that mind-body connection.
Yes, and that's a huge piece of this. And initially, I thought when these mind-body connections talk in the 90s, it was more this new agey stuff, and I thought it was really hokey. But then becoming a researcher and going on an academic track, I was really interested in learning, well, if it works, we should try and practice it. And then the mind-body connection, quite evident that this is one of the main things that works. The understanding mind-body connection and all the techniques that kind of go along with it really make the direct impact on learning how to manage the pain. So initially, I turned a 180 in believing that there's a lot to do with how do you control how your mind can control parts of your body. And
Right.
we actually can actually graph it and image it when we take a look at brain scans and
Wow.
functional magnetic resonance imagers,
Those
fMRIs.
yes, right,
So,
right.
and then we can actually take a look at, as well as body scans, we can actually take a look where the body connection happens with specific interventions.
Wow, that's
very,
amazing.
very helpful stuff to do.
Yeah.
So there's good science behind it.
So we're going to take a break, and when we come back, we're going to talk about the use of medications, most
Sure.
notably opiates and marijuana, in the treatment of chronic pain,
Sure.
and how that you work with those medications in your work.
Okay, great.
For 1 in 4 Americans, mental illness hits close to home. And since 1931, Silver Hill Hospital has also been close to home. For individuals and families facing the challenges of mental illness, Silver Hill offers a highly trained, compassionate staff that provides state-of-the-art care in a beautiful and private setting. If mental health issues hit close to home, remember, there's a world-class psychiatric hospital right in the neighborhood.
Welcome back to Straight Talk with Tracey. I'm here today with Dr. Christopher Cutter, who is the Program Director for the Chronic Pain Recovery Center at Silver Hill Hospital. Again, thank you for joining us, Dr. Cutter.
Happy to be here.
So we're going to move into what most people think about when they think about pain, chronic pain, acute pain. They think about opiate use.
Yes.
So let's talk about the use of opiates and how it is affecting the work that you do.
A topic I really care about a great deal about. All right, so one of the really nice things that has started happening with opioid use epidemic plaguing our country and many other places around the globe is that they're starting to crack down on mishandling and misprescribing the opioids. And it's very, very tricky on how to prescribe opioids through addiction, through pain. So let's take a look at, what's a really helpful way of prescribing it.
Right.
So I'm not a physician. However, I've had quite a number of years running an addiction medicine laboratory through Yale School of Medicine. And it was my lab and a lot of my studies, and co-investigated a lot of studies on opioid prescription, opioid dependence, and opioid dependence with co-occurring chronic pain. So we take a look at where people usually come into my studies and how we can be helpful. Usually the person that walks in the door, and I find the same thing, almost the same thing universally at Silver Hill Hospital, is folks have been prescribed these short-term acting opioids. And so we think about Oxycontin, oxycodone, or even if it's extended release Oxycontin, oxycodone, it's still a short-acting oxy, or a short-acting opioid.
Meaning?
That means the opioid will bind to the opioid cell receptor for a period of a certain number of hours, maybe like 6 to 8,
Okay.
and then come off of it.
Okay.
And it will be very helpful for those 6 to 8 hours. An interesting piece of it is, though, the cell receptor is not really designed well for short-acting opiates. For acute pain, it's probably incredibly well indicated for breakthrough pain, say for oral surgery, or you'll go into for surgery in general. But to use it for a long period of time doesn't make sense, because then you build up this incredible tolerance. The opioid receptors start not liking this stuff.
Okay.
And so then you need more and more to get the pain relieving effect, and eventually you stop caring about the pain relieving effect, because either dependence and or addiction can happen in that point, where the person doesn't feel normal without it. And then it affects reward systems of the brain and craving areas of the brain. So the craving, the pull, the intensity to want the opioid takes over. And it becomes less about pain and more about the medication, and thinking that the medication is the only savior at this point. And it's really hard to pull somebody away from that. Now, when I was seeing these patients in either setting, I like to actually work with different medications, as do my addiction psychiatrists and my pain management physicians, to do several different options. And this truly depends upon the case presentation. Switch them to longer acting opioids, such ones that like Suboxone, buprenorphine, methadone, which will have a nice stable dose that's sitting on the opioid receptor, but that will not put somebody in euphoria
Okay.
and will not put them in withdrawal. It keeps them in a nice long-acting zone where they're not going to worry or not having cravings for the opiate. And this is tremendously useful when I'm treating a pain patient, so I can kind of see where the pain is. So we don't overprescribe, we don't underprescribe, we kind of see where they're at, and then eventually we do a taper trial off to truly see where we can make the impact on managing the pain, where the other skills, the non-medication related skills will come on in. Another option, I'm not saying it's the only other option, the other option is to taper off entirely, because sometimes we have something called opioid-induced hyperalgesia, where somebody's pain threshold, pain sensitivity, where say it's resting right here, if you keep using short-acting opiates, you get hypersensitive, and that
To any pain.
any pain, even just
A headache.
sensitivity, just
Right.
shirt going on, like, ow, that shirt hurt.
Oh, wow.
So, but not many people buy that, but until they actually come into a program and start lowering it, and then they eventually see usually after 2 weeks, they start feeling better.
Okay.
And I'd say that's-
Rebuilding that tolerance that can be
Yes,
rebuilt.
yeah,
Okay.
Oh yeah, thank you for pointing that out. It absolutely can be rebuilt, and it's a really relieving and freeing experience when you see this in a patient. It's actually one of the reasons why, when we're all going in the pain field doing this, just watching that occur, it's
Right.
a really cool experience, watching somebody go through that,
Right.
take their life back.
So the short-acting opiates, good for acute pain,
Yes,
not good for chronic pain.
correct. And how about I go into that a bit?
Yes.
Acute versus chronic.
Right.
So acute pain. So stuff of what we were taught as kids. You scrape your knee, you get a cut, you get a burn on the stove, or you break a bone. You should actually do something to that. You should put a splint on it. You should put a Band-Aid on it. You should take a medication to help you through maybe some little pain through healing for a little bit or period of time. Somebody's actively doing something to you. And you rest. You don't move. You want to make sure that part of your body heals. You take it quite easy on it. Now, and that's short term. And there's obvious tissue damage. It's incredibly apparent that there's
An injury.
Injury. Thank you. Chronic pain is quite different. Chronic pain, there's no evidence. You can't see it. All the healing most likely occurred. Yet the pain signal is still firing. And the only real way to manage the pain, to treat the chronic pain, is to actually get mobile again, rather than be sedentary. The more mobile we get, the stronger the muscle tissue can develop and more elasticity, so you can actually help pain management that way as well. At the same time, the taking pills in short-acting opiates doesn't work. It actually makes things a bit worse after a period of time. So that's where we try to make a difference on this one. And some people tend to want to do surgery after surgery after surgery to think that would try to cure the pain. And we eventually get to the point of diminishing returns, that the surgery is just not going to be the answer, that we have to learn how to manage it. And we've had people come in our program at Silver Hill with upwards of 15 to 20 surgeries trying to find that magic bullet, but it's just not the way to go any longer.
Right.
Because we were kind of indoctrinated as children, like, well, when you're in pain, you
Do something.
do something for it.
Right, right. An external intervention.
Correct.
So what about the use of marijuana for chronic pain?
A very important and very hot topic right now. So the use of marijuana is tricky. So we have a lot of people talking about it in different conferences now that I'm either attending or presenting, and we all kind of come to the same conclusion at this point. Well, not all. It's split, obviously, but the majority is going this way. It can be useful. It can be useful, and a lot of people really do swear by it. And as healers, we want our patients to feel better, and it would be wonderful to be able to prescribe something that we know is going to be useful, that's maybe has natural medicinal properties rather than a synthetic. Here's the trick, though. We have no idea what we're giving a patient when we're prescribing marijuana. So there's so many different strains of marijuana, and you have strains like different types of plants being grown. And when you design a clinical trial and you're using a specific medication, you know down to the molecule what's going in to the patient.
So at this point, would you say that the research is more, or the effects, positive effects that people are talking about, is more anecdotal because it is so uncontrolled?
Correct.
Okay.
So that's where that's where we're at, and this is where I'm going to stand right now with it. But I do believe natural healing methods are incredibly important, and it's worth further investigation. And happy to follow along and contribute to that field.
So let's talk about some of the non-medical interventions or healing processes that you utilize at the Chronic Pain Recovery Center.
Yeah, and those are, so yeah, one big thing I'd like to talk about today. So I take a look at, let me just preface it with a background on this one. So when I grew up watching my father do well in his business, he did something quite interesting where he wanted to make sure he did the best, highest quality of care. And the care was to car vehicles. So he ran a car shop. But he was always on top of the latest technology, always. And he would always integrate that in the system, and then he would make sure that the training was there, that his technicians were truly trained in how well they can actually repair a vehicle. And I just grew up in watching this to do evidence-based treatment with a car.
For the cars, yeah.
So, and then I take the same approach when I run a program and when I'm running research, is what is the absolute best intervention that we can do? And we're not convinced that the best one out there is working, let's design and make one that's even better. And making sure the delivery is done by true experts that have the highest level of training out there. So what I like to do for the self-care treatments, as I like to call them, is I take a multidisciplinary team, that not one treatment discipline has the answer, that I have to pull champions from a lot of different fields. So the ones I like working with right now, and that also when we take a look at integrative teams and really strong chronic pain programs, they have the same very common elements. They have a psychologist for the psychological interventions, and they have a strong social work component for really making sure the aftercare component is very well attended to. You have obviously the addiction psychiatrist and pain physicians that know how to diagnose extraordinarily well. And then you have your physical therapist to make sure there's a lot of mobility and activity happening throughout the program. And that's a big piece of this, is getting mobile, getting strong, getting flexible, and increasing mobility. The psychological interventions, which I'd like to talk about most, which is the field where I have the most experience in, is designing psychotherapeutic interventions for co-occurring chronic pain and opioid use disorder. Take a look at empirically supported treatments. Cognitive behavioral therapy, acceptance commitment therapy, or ACT for short, and then elements of mindfulness are really where the field has turned toward effectiveness for helping manage pain. So there's a lot of different psychological interventions that really will work extraordinarily well with a chronic pain patient. And then we're thinking folks with co-occurring addiction, with co-occurring depression, anxiety, we can really kind of capture a lot in learning these different techniques. And just like learning a skill, like say you're learning a musical instrument, the more you practice it, the better you're getting at this. And we're actually trying to get a person quite skilled in managing their pain through psychological interventions. Let's say that takes their pain down 1 to 2 pegs. Then we have our physical therapist to get them to get more mobile and stretch and do proper posture and what have you, or sleeping techniques. Let's say that does another 2 pegs. And so now we're like reducing pain numbers and slowly and surely. Proper pharmaceutical management, that's another like 1 or 2 pegs. It's not actually a big one. It's actually the same as the other interventions.
Right.
But then the last piece is what I really like focusing on, is complementary and integrative medicines. And so these are the type of medicines that we talk about, that mind-body connection that we were talking about earlier. So these, they might be considered unorthodox, but they're really not. They're being tested. I've either tested some of them, or other people are doing, there's a big field of complementary and integrative medicines right now. You would take a look at well, what can we do to distract from the pain signal? What can we do to actually help a person connect that might make that mind-body connection a little stronger? And it might not be the classic Western medicine. So we take a look at how we do meditation very well, and how do we actually get create a sense of mindfulness that we can truly distract, or we can truly be like quiet our mind in a way that things are not just scattered everywhere. I usually like finding how different types of physical exercises are helpful. Music, Tai Chi, yoga. Every one of these type of things I've done a trial on, and they're extremely helpful. And there's ones that I'll even try to, I'm not sure are helpful, but I'll try and I'll test them out to make sure they'll work. And if you capture all those under one umbrella, you can just take the pain and keep chipping away and chipping away and chipping away, and you get such a nice lower pain number. By the time somebody leaves, they have a lot of tools in their toolbox to actually combat a pain flare or the consistent daily chronic pain.
Right. So diverting their thought time from this pain to other things, being able to manage their thought time in a more effective way.
And if you if you can control your thoughts, if you can control your emotional state, if you can control the behaviors you engage in, you really have a really big head start.
That's right.
On how to manage life in general, but definitely manage pain and addiction and depression, if you will.
Great. So we are in Pain Awareness Month. September is Pain Awareness Month, so there's a lot of resources available. Certainly our website, Silver Hill Hospital, and the Chronic Pain Recovery Center would be a great place for people to start. I want to thank you very much, Dr. Cutter, for joining us today. Lots of great information. And
thank you for having me.
You're very welcome. We'll see you again next month.